শুভ সন্ধ্যা। কেমন আছেন? ফিজিওনিউজ 24 এর মাধ্যমে আসলে আমরা চাই যে বাংলাদেশের ফিজিওথেরাপিস্টদের সাথে, বিশেষ করে বিখ্যাত যারা ফিজিওথেরাপিস্ট আছেন তাদের সাথে আমাদের জ্ঞানের পরিধিকে হয়তো একটু ভালো দিতে, তাদের কাছ থেকে আমরা যেন কিছু শিখতে পারি। তো সবসময় আসলে আমরা প্রত্যেক সপ্তাহে চেষ্টা করে থাকি আপনাদের সাথে নলেজ শেয়ার করি। তো বিগত কিছুদিন হয়তো বা বিভিন্ন ঘটনার কারণে আসলে আমাদের দেরি হয়ে গেছে। তো তার জন্য আগে থেকে দুঃখিত। আজকে যারা আমাদের সাথে আছেন লাইভে তাদের জন্য একটি বিশেষ দিন। বিশেষ করে আমরা যারা ফিজিওথেরাপি চিকিৎসকরা ছোটবেলা থেকে দু তিনটে নাম জেনে মানুষ হয়েছে এবং তাদের মধ্যে একজন হচ্ছেন ডক্টর পালসন স্যার, যার কথা শুনে আমরা ছোটবেলা থেকে বড় হয়েছি। তো আমি আসলে খুবই আজকে আনন্দিত যে তাকে আমরা পেয়েছি এবং তার গুরুত্বপূর্ণ কিছু সময় আমরা পাবো। তো আমাদের সাথে সারা পৃথিবীরই কিছু না কিছু পার্টিসিপেন্ট আমাদের সাথে প্রায় যুক্ত হন। তো তাদের সুবিধার্থে আসলে আমি সরাসরি ইংরেজিতে চলে আসি। So, good evening, everybody, and I would like to invite you all for today's special occasion because from our childhood in physiotherapy profession, we have heard some 2 or 3 names. Among them, I heard Paulson's name. Today, we are very glad that we have Dr. Paulson sir with us, and he is from India, and he is a very famous person, not only on India, all over the world. And a lot of his students are now going robbed in the world, in the physiotherapy field. And I would like to request sir to give us your valuable time. And from my childhood, I have a dream that I would join your classes. But it's a we are bad luck or we are lucky enough that from distance we can get the chance. So I'll not kill your time because everything is very important. So today, sir will going to rock, and there's the new topics. I think for our Physio News 24, especially that is everybody can observe today. Sir will going to utilize his every minutes, and also he will going to demonstrate our very practical things. Thank you, sir. And now floor is yours, sir. Thank you, sir.
Yeah. Thank you, Dr. Shantanu. He was a very humble and a very good therapist and a very popular person in Bangladesh, I know. And he is also popular in West Bengal and India also, you know. So today everybody is asking me who is Dr. Shantanu. You know? So thank you, Shantanu, for inviting me to share my knowledge with you. I think you are doing a wonderful job to the community of physiotherapists by inviting all good therapists to the floor of your Physio News 24 and give an opportunity to youngsters and budding therapists and students to learn from them, and to at a cost of nothing, you are spending your valuable time, your resources and everything. I really appreciate you, and it's a big honor for me to share in your news channel. And I thank you very much, Dr. Shantanu, for doing so a wonderful job. Please continue, and we will, from India, we will support you in all means to promote the community of physiotherapy. And I would also like to thank my management, Dr. Singh Narayanan, my trustee, Dr. Narayanappa sir, and Satish sir, Dr. Vasudev sir, and our Karnataka State IAP, Dr. Iftikhar Ali, for contributing a lot to the community of physiotherapy and doing so. Okay. Thank you. So, not to waste anybody's time over here, let us go to our presentation. Okay. Yeah. Can you can you see the screen? So much is Can you all see the screen, Doctor? Dr. Shantanu?
No, no, now, sir. Yes, sir. Now it's okay, sir.
Yeah, yeah, fine. Thank you. Okay. So let me introduce myself. Person, the working in Padmashri Diagnostics as a consultant and a professor in Padmashri Institute of Physiotherapy and a founder of Federation of Indian Manual Therapists. And I'm very fortunate to be in the community of physiotherapy to treat and teach and spread the knowledge of physiotherapy and manual therapy to all the people. So today's topic is all about our approach on that is my approach or how I look in okay into a cervicogenic headache. So everybody says that we have cervicogenic headache can be treated with manual therapy. So as we all familiar with that. But what I have sandwiched is a few concepts which has been taken from pioneers like Dean Watson, Gwendolyn Jewell, and many other people, Toby Hall, and many other stalwarts who have contributed to the cervicogenic headache with that concept. And I have put across my experiences into that, and I have done this presentation, with my full heart. Okay. So let us say, like, when you say who will get, neck pain or who will have neck involvement. So anyone who has a lot of issues with whiplash injury or, the nerve involvement or non-traumatic or those who have any kind of involvement with presentation with cervicogenic or all these people, which will be considered or which will be causing the neck or neck pain or the headache here. So when you say headache, we can have hundreds of headaches. So that's the reason why I look upon like plenty of reasons why people get headache, and it could be something which where we can play a role. But at the same time, we need to know there are a lot of red flags, okay, which has to be identified. So, for example, hypertension can cause the headache, or even the carcinoma can cause us the headache, or even if you consider people having any big SOL or even a lymph node involvement can cause us the headache. So we have to look upon before we treat. We always consider what could be the adverse effect of our treatment. So that means red flag, yellow flags, black flags, and blue flags has to be identified. So if you want to identify that, good clinical reasoning has to be done. So for me, what is important in manual therapy means clinical reasoning. So what is clinical reasoning? Clinical reasoning is a thought process associated with the therapist for a better outcome. So what happened is I have hundreds of tools to treat the patient, but I need to know what tool to use for this patient. I need to know how to identify, how to diagnose a patient. So for example, if you take headache, is that because of cervical region? Is that because of tension? Is that because of sinus? Is that because of eye? Is that because of something else? So you have to keep going on. So we really need to know the differential diagnosis. So if you want to get differential diagnosis, the clinical pattern has to be understood. If you don't understand the clinical pattern of any condition which we treat, then it becomes difficult. So that's what I always say to my students and my friends and everyone. When we share, we have something called forward reasoning, and we have something called backward reasoning. So backward reasoning is, as a student, when I was a student, when I got exposed to manual therapy first time, I go through a procedure like right from the name to the diagnosis or name to the clinical presentation. But once you become an expert, you quickly do a quick test. Within 5 minutes, we will be able to identify what kind of clinical pattern that patient fit in. So this is very, very important for the person to identify what kind of cases we have, right? So please remember, manual therapy, I'm going to teach you some technique, but more than that, it is a clinical reasoning. So I would contribute or tribute to Mark Jones, who my tutor, my mentor, who has written a lot about clinical reasoning. I still remember my postgraduate time, in which I have spent a lot of clinical presentation with Mark Jones and Jenny Roberts and David Butler, who have contributed a lot to the manual therapy thing. But you also take it forward once you understand what we are trying to do and how we are going to utilize the technique into your patients. Okay, so that's what you're going to see here. Right. So now you see there we are going to see an integrated manual therapy for cervicogenic headache. So when you see how many schools of thought in manual therapy is there, we have n number of schools of thought. What to choose? And everybody says, even I hope you would have come across taping, or you would have come across cupping, and many more, IASTM, and many more has come in order to contribute or help the physiotherapists to do better for the treatment of the patients. Okay. So when headache comes, we also have a lot of options to treat with, but what to treat with, how to treat with. So this all will be answered only when you have a clinical reasoning. So please remember, there are three components of clinical reasoning. One is called knowledge base. So what is the knowledge base? Our theoretical knowledge, anatomy, or biomedical sciences, or exercise therapy, or electrotherapy, or clinical orthopedics or PT in orthopedics, very important, and practical knowledge. So we would have been exposed to the patients right from the second year to till date. So we need to put both the things together. That's what I like in Maitland concept when he says brick wall theory. I hope all of you would have come across. If not, brick wall theory is nothing but a semi-permeable membrane between theory and practical. So we need to know what to take from theory and what to take from practical. So we need to have both the knowledge, okay? Because physiotherapy is a skill-oriented course. You can't have a theoretical base alone, or we can't have a practical base alone. So we need to have a sandwich of both, which will help us to do. That's what Jeannie Maitland always talks about, and everybody acknowledge that all the manual therapists in the world acknowledge his concept. And I studied from his school of thought, that is from the University of South Australia. Very proud to being studied over there, which gives the biggest foundation for anyone. I would recommend all of you to have a visit to that university, which is very, very important. Okay. Come. So right. So no brain, no headache. So who is the pain generator? Is that the brain, or is that the structures, or is that something else which causes the pain? So Zuzman, another legend in the pain sciences, who talks about the involvement of brain in the chronic presentation. And he has done a study about chronic low back pain, and he found that when you have chronic low back pain, that's what I mean is more than 3 months, that is a lot of changes in the brain. So you have to treat the brain. So how do you treat the brain as a physiotherapist? So we need to play a role of clinical psychologist. We need to play a role of kind of advising, counseling. So please remember, today's world, education to the patient is very, very important. about the condition is very, very important rather than the technique. So always you try to remember the conditions, always you try to remember the kind of need import which we need to do about the condition to the person rather than talking through only about the treatment. So any patient comes to me, what is the reason for the pain, why they have got this spasm, why they have got inability to move. And today's world, people are oriented towards functional status. So that's what we see in the ICF model. So if I'm not able to turn, if I'm not able to turn the neck, what could be the reason for that? If I have a pain, or if I have a stiffness, or if I have discomfort because of the nerve, all these factors has to be considered, has to be explained to the patient according to their level of knowledge. So you don't need to say everything, but at the same time we should explain them. So please remember there is a big shift in the way in which we look into the manual therapy. That is all about education, all about reasoning, because the clinical reasoning has been in the field of physiotherapy or manual therapy from 1990s. But in medical, the clinical reasoning has been there from 1950s. Why medical field is flourishing much better than us is the reason. So we need to have a lot of clinical reasoning, and we need to have lot of understanding education to the patient before we start with the treatment. So please remember this when you want to do the procedure. Okay. Right. So this is one of the commonest, this is one of the commonest thing which you would come across in the web as soon as you type Google. So because what happened today, physiotherapist or a patient, we always depend upon the Google. And you see here, I have seen a patient with TMJ having headache. Okay, so you need to think about TMJ joint. You think about sinus, retroorbital pain, something similar to this picture, where you can think about a kind of headache. Okay, then cluster headache, yes, tension. I know how many of us today, Monday or any other day, like when we talk about Tuesday or Thursday or working days, all the working days are a tension days at the end of the day. We get a mechanical leg pain. Okay, so we will be having a tension type headache presentations also. And we have something called migraine headache. Okay, so can we do that? Yeah, we are limited with that, and we are talking about cervicogenic headache. There is a neck headache. So they're very simple. What who we can treat with manual therapy very confidently and very effectively is if you have a pain on the occipital region and as well as on the frontal or parietal lobe area with any kind of retroorbital pain, then I could consider them they are fit for cervical mobilization. Otherwise, we have another patient I happen to see today, who had a trigger point at the levator scapulae. So when I tried to release that, his headache got better. So you have various reasons which need to be constrained or which need to be looked. So migraine or trigger points or TMJ dysfunction or postural or any, you would have seen a lot of people getting into forwarded posture. Forwarded posture causes the suboccipital extensor muscle tight. So when you have suboccipital extensor muscle tight, the mid and lower cervical movements will be limited. Okay, so we need to release that in order to get it better. And another kind of presentation which will mimic like a headache or a cervicogenic headache is an occipital neuralgia. So you should be, I hope all of us would have come across greater occipital nerve and the lesser occipital nerve, which could be the reason for causing the discomfort here. Okay, so we have plenty of literatures right from the year 1995 to till date about cervicogenic headache. So I wish all of you to follow Gundlach Joel, who has contributed in the year 1990s, and then later on, it was taken over by Dean Watson and Toby Hall, and many other people contributed. Because today we have to be more evidence-informed practice. So we need to read, we need to understand identify, what kind of literature or what kind of, research goes on with each and every presentation. All right. So when you say cervicogenic headache, okay, it is only 2.5 to 4% of the total headache. So it is not all the patient with headache will have a cervicogenic headache. So please remember, not all the. I've seen people saying that, like, they change their headache for everyone. It's not possible. So only 4% of the total headache can be treated successfully with cervical mobilization. Okay, remaining, that could be a tension type headache. So that means they have involvement of levator scapulae, or it could be because of the upper trapezius tightness. It could be various other factors which has to be considered in. Okay, so according to the Journal of Headache and Pain, so what is headache? Cervicogenic headache, unilateral head pain without side shift. Okay, so how do you know that side shift is? You have to identify the angle of mandible. So if I have a side shift like this, so that will be something different. What do you mean by that? That could be a disc involved. Neck positions. So if you do like physiological, in a sense, you don't do a flexion up or extension or a lateral flexion or rotation. You try to do a movement, which could causes it. And the simplest test, I would always you tell or everyone, and that's what Toby Hall also says, that flexion rotation test. You do full flexion and then rotation. If you have limitation and if you have a headache, then you can say that it could be a cervicogenic headache. And people with cervicogenic headache will have a neck deficit range of motion. Please remember, rotation will be limited. If rotation is not limited and they have a headache, it could be something else. And they can have a shoulder pain, they can have an arm pain, or they can have pain coming very rarely and anterior. And this can be gold standard for diagnosing is anesthetic blockade. So that's a gold standard to find out headache, classification. So please remember that unilateral head pain without side shift, and they get that neck deficit. That means the range of motion in the neck will be restricted, particularly the rotation one. So if you look back in 1997, okay, by Goodline Joel, so she has done a wonderful job for the Society of Physiotherapy with her contribution, in doing researches and giving a lot of inputs to different people. And so she says that painful upper cervical joint dysfunction. So pain function and impairment in the deep neck flexors. Okay, so if you have impairment in the deep neck flexors, so if you see here, we are talking about these three segments: 1, 2, 3, C1, C2, C3. So you have OC1, occiput, C1, C2, C3. Try to remember these segments alone. Okay, painful upper cervical joint dysfunction. So what movement we do with that? We do a nodding movement. Okay, we do a full rotation. All this rotation takes place in the upper cervical spine. So impairment in the deep cervical flexors. So all of you know, when we talk about any kind of upper quadrant involvement, they'll have a tight, sternocleidomastoid. So what happens is, I do that, I get forward, and we get into a forward posture, we get a tightness of sternocleidomastoid. So what will happen? It will weaken the deep neck flexors. So one of the simple instruction what she has developed, and we can follow that, is could be keeping the tongue on the upper palate, keeping the tongue on the upper palate, and then do the tuck the chin in will strengthen the deep neck flexors. So this is pretty old, like in the 90s we have been doing it, but it's for anyone who is not aware of it should be doing as a physiotherapist rather than doing our simple isometrics or MBT technique. Scapular postural muscles. So why people get forward and posture? So forward posture could be because of rounded shoulder. So what will happen? You will get the involvement of the pectoral tightness, and you will have involvement of the brachial plexus, and as well as you also need to think about weakness of the scapular muscles. So if you have a headache patient, okay, I would tell them to get into the PNF of scapular muscles. Okay, so how do you get the PNF? It's very simple instruction. You go up and down. That's 12 o'clock, 6 o'clock. Okay, and you go 1 o'clock and 7 o'clock, and then you do 11 o'clock and 5 o'clock. So you activate all these muscles. So PNF you can do like by giving a restriction or kind of resistance. Sorry, you can give a resistance and then do the up and down movement, or you can give a resistance to the 1 o'clock and 7 o'clock. So make it easy where you can try to think about weak muscles. So as we all know, like because of a lot of studies of middle trapezius, lower trapezius, serratus anterior is always weak, and upper trapezius and levator scapula is tight, and scalene is tight, sternocleidomastoid is tight. So we have to do the muscle length test for the person. So when we do the muscle length of the person, we will be able to find what is tight and what is weak. And then you consider about cervical anesthesia. So nowadays we talk about a lot about this Swiss ball exercises and all the other things which we need to do. And I would do using the person with Bosu ball. Okay, Bosu ball, Bosu unit you can get, and once you get that Bosu unit and teach them the exercises, you will feel that the patient gets better. So that's a fantastic thing what she has laid down for all of us to understand about this. So why do you get cervicogenic headache? Which nucleus. So the trigeminal cervical nucleus convergence with the afferent trigeminal nerve input. That's the reason why we get this. So you can have a better picture, like you could see here. You could see here, like when you have a basal occipital involvement, okay, OC1 involvement, you see here the presentation up here. Okay, you can see the red one, and they can have some kind of a discomfort over there. And if you have interspinous C1, C2, which is the down segment, okay, which need to be palpated. So if you have a headache patient, which is a cervicogenic headache, you have to identify the basal occipital area. You have to identify the C1, C2 interspinous, do the C2, C3. So this is what forward reasoning. So you got a patient who has headache. You are doing flexion, rotation, test. Okay, he got it positive. Then you have to. Why is this not clear? Can you hear me well? All okay? Dr. Shantanu?
Sir,
Sound is not clear?
yes, sir. Sound sometimes is breaking, sir.
Yeah, maybe because of the network.
Yes, sir. Now it's okay, sir.
Okay, thank you. Fine. So we'll continue. So basal occipital, it is OC1. Okay. So you have to palpate basal occipital area. You have to palpate interspinous C1, C2 area, and you have to palpate interspinous C2, C3 area. So please remember these areas has to be palpated and has to be mobilized. You will get better. Okay, it's a very simple formula, and this can be done effectively, efficiently by knowing the body landmarks, and as well as knowing the anatomical position of the segment here. And this is another picture which tells you about how difficult or how easy we can pick it out with the trigeminal nerve nuclei and the C1, C2, C3 convergence. You can see here with the presentation where we talk about the convergence of the so-called trigeminal cervical nuclei with the C1, C2, C3. So look back with this. I can show you with the pen here. Yeah. So you just try to see this. Yeah. So that's a place, where you look for the convergence area here. Okay. So let us try to look upon with the movements. Okay. So when you say with the movements, so what happened is what kind of movement what we are trying to do, we are going to do, or what are the things which we need to assess. So you see here, when we talk about the presentation again, okay, we're going back to the presentation. There you go. Yeah. So consider this OC1 movement. Please see that you can see this is the kind of movement area which we need to see. So as I told you, occipital area which you need to evaluate. So from the greater occipital protuberance, we have to come down to evaluate the C1, C2 level. So you have to remember three things. Okay, one is occipital basal area, C1, C2 interspinous, and C2, C3 interspinous. So this is the forward reasoning. If you have a cervicogenic headache, you straight away do that. So in order to understand here, you see this, how the movement takes place well. Yes. And when we do lateral flexion, because very important, lateral flexion because of the involvement of the LR ligament. So you have to do the movement. This is very tiny movement, but we understand if you watch the facet here, okay? So what will happen is the facet will cause a compression on one side and open on the another side. We'll have a compression on one side and open on the other side. So please remember that if I do lateral flexion to left facet will be closed, right will be opened up. So we need to know whether opening is causing the pain or closing is causing the pain. Again, you could see here with a segment where you have a translation movement. So which is very important to understand. With the translation movement, we will be doing like most of the people who does dancing. You would have seen dancers. So we have our megastar Chiranjeevi, okay, who dance like this. You would have seen that where you move. That's the movement of and you can see here the C1, C2 movement. Okay, so when you have C1, C2 movement, what happens is you need to look upon again and again. Please see the transverse arch. Okay, the transverse arch is on the side, one over here, and you have the posterior arch. So when I do a movement of rotation, okay, one goes forward, okay, the right side, consider right, okay, right goes backward here and the left goes forward. So that's what we say as the anterior and the posterior. So consider this and you do the movement, okay, you do this movement where you have the transverse arch. You consider this as a transverse arch. I'm doing a rotation. When I do a rotation, the right goes backward and the left we will be mobilizing the same. So please remember that. And then C1, C2 flexion extension. So that's the reason why I like Carlton Board's principle, who talk very biomechanically. The C1, C2 movement takes place in direction with the angle of mandible. So that's what what Mulligan follows. The C1, C2 has to be pushed towards the angle of mandible. But I would say always we have to push towards up when you do a mobilization to the cervical spine, and when you do lumbar you should push towards the tail. So that's how the orientation you could see here, okay, where you can see this orientation of the facet joint. So facet joint orientation which you can see, which will be like here, but whereas when you come to C3, C7 it is different. We don't need to talk about that, but let us try to fix it with C1, C2, C3, where movements, particularly in the upper cervical, that is the OC1, C1, C2, and C2, C3. The movement is towards the angle of mandible. And you can see here C2, C3 movement. Okay, so this is about C2, C3 movement. You see that the spinous process, is moving from right to left. So that's why we choose particularly the transverse vertebral pressure, or when we do the movement from side movement, or people say as a lateral glide. Okay, and I and many other people who talk about the suboccipital extensor spasm, the reason for deviation in the spinous process. That's what Dean Watson has done an extensive study about this, saying that if you have a cervicogenic headache, there will be deviation of the C2 spinous process. So what happened is the C2 spinous process will deviate to the side because the suboccipital muscle will go for spasm. So what happened? We need to give a pressure, we need to give a movement, or we need to give a central PA for 30 seconds or 45 seconds or 2 minutes or 3 minutes till you get the deviation done. So please remember that this is very important tool, one of the important treatment technique advocated by Dr. Dean Watson. And you can see here general rotation. So what happened when we do general rotation? You will have all the movement taking place in the rotation taking place there, which could be the reason for the spinous process moving to the side. Okay, so we are going to see now the practical sessions. So we are going to move into the next camera. Dr. Shantanu? Dr. Shantanu? Yeah. We are going to move to the next camera. So I'll stop this camera. Right.
maybe some technical issue. So please, viewers, just wait for a few seconds because sir is going to present the practical session now.
We are on the backstage. Yeah. Can you swap to the camera, doctor?
Yes, sir.
You focus.
Sir,
Can you swap to the camera?
okay, so
I should stop share.
yeah, you can stop here
I,
and you can set your camera, sir.
yeah, yeah.
So you can take leave from here, sir.
Yes. Leave studio.
Yes, sir. Then connect with your phone. Please just wait because I want to show our practical session. That's why he's some technical issues there. He's trying to connect the camera. So please be patient.